let's come back to cost for a minute. Can the Centers for Medicare and Medicaid Services, CMMS, Medicare, can they consider cost when they're approving or disapproving therapy?
No.
They're prohibited by legislation, right? Does that make sense? Anybody? Does that make sense?
Does it make sense? You're never going to find a legislator that's going to pass that.
Well, the legislation says
it doesn't
they don't
make
raise
sense.
taxes, and yet they don't allow us to find the most cost-effective therapies. And so, how do you square those two? As private payers, when we get a $150,000 a year drug, do you know how we finance that? Through premium increases the following year. And that's exactly what's happening with taxpayers. So until we find a way to consider cost objectively, we're going to have to continue to pay more for healthcare than sometimes we might want to.
Are private payers using comparative effectiveness research to steer coverage policies?
In some ways indirectly, but it gets back to the thing that you were talking about earlier regarding rationing.
Okay.
And I don't know if I'm completely answering the question or I'm answering another question, but one of the things that goes on in the private payer world is exactly what John alludes to, which is that costs are allocated and spread based on experience, such that the plans, which basically operate like grocery stores on 4 to 6% margins, not like the people who make
You're
our...
at 4 to 6?
Well, I hope the stock price will work with you. The stock price hopefully will rise on my statement of that. But General Electric, Apple, Microsoft, their margins are 20%. But payers, both private and regional blues and smaller held plans, the margins are not big. So every year we reallocate the monies. Okay. And what happens is, through benefit design, and you're seeing this with the Accountable Care Act, there is informal rationing going on already, because we know that, for example, when patients start to pay more than $350, going up to $500 per month for a copayment and coinsurance for oral oncology drugs, the adherence drops off dramatically. And so we're creating a multi-tiered system in which rationing occurs by the financial burdens we put on people. And we put those burdens on people actuarially because exactly what John said, because we have decided not to fix the problem on the front end.
And we call that underinsured. And it's really a no value proposition for everyone. I mean, there's very little value in getting a 1-month prescription of a dispensed PO oncolytic agent. Mm-hmm. Nobody wins there, including the patient.
It's not unique to oncology, right? There's psychiatrists out there who are claiming, you only got 3 sessions, 5 sessions, 10 sessions, then it's cut off. This is a spectrum-wide issue.
Yes.
But I'm getting a sense that you actually think that comparative effectiveness research could be used effectively if somebody would let you do it.
Well, because it would actually eliminate the false economy thoughts that come about when we create policy.
Okay. Well, the Institute...
The point to this, too, I just don't want to lose sight of, is that, the world doesn't stand still while we're conducting a study. I mean, you've got new areas of the pipeline that are evolving at times. And
there's a horrifying thought. It's not standing still. Yeah. I can't keep up.
But challenges gives us something to come to work for every day. But I would just say, there's a time lag and a time element here that, if you get to the end here and you've got yet a new piece of information or new piece of technology that became part of the equation, well, your CER is not as relevant.
Yeah. It's interesting, though, because in the lack of CER, comparative effectiveness analysis data, we often say we're going to look at cost. We don't have any evidence that they're different. So we're going to assume that they're similar, and metastatic castrate-resistant prostate cancer is a good example with the oral therapies there. There's a significant difference in cost. The trials were done in similar study populations, so in the absence of good comparative effectiveness data, we're simply using cost alone.
I think there's cost, but I also think you pointed it out earlier, and it's the side effect profile as well. So those are drivers in the decisions, but I think you're right. I think that's been distilled down to say, if we really can't tell the difference, why should we be paying a premium?
Yeah.
So
because it's a distinction without a difference, is that it? Right. By the way, there was a play, right? Stop the World, I Want to Get Off. But fortunately it is, the good side of what you're talking about is that the implication is it isn't stopped because it's getting better, not because it's getting worse. That there are improved therapies, and now something needs a reset, we're going to go reevaluate everything, right? So, when do oncologists have that end of life and palliative care discussion with patients that everybody talks about?
I'm not sure that solely rests with the oncologist. there's a care team that's out there, and there is a conversation to be had not only with just the patient, but the patient and the caregiver, and a team approach that I think we've largely avoided.
Even the oncologists have avoided it. You guys are the ones I always thought were doing it the best. No?
There's process. So this whole discussion about death panels and a Medicare code for an end of life presumes that there's like a showdown at the OK Corral. You sit down and today's the day. That's not the way it works. There's a process. So you introduce the concept over time. You play off cues, but you need to go into the relationship with the patient with the idea that one of my goals of delivering good care to this patient is to have this discussion so that I know what the patient wants.
There was a fascinating study published in the New England Journal, October 2012. Janice Weeks found that 81% of patients who had metastatic incurable cancer, colon cancer, thought they were getting curative chemotherapy. And it's not because their oncologist didn't tell them they had incurable cancer, it's because the patient heard something else. So what we've done in our integrated delivery system is when that patient is diagnosed with metastatic cancer is to sit down with the family members and the patient and talk about what that means and to assess very early on what their priorities and preferences of care are. And when you introduce it early, it doesn't result in that, why are you talking to me about this now phenomena that all the oncologists are worried about.
Got it.